Just so you know, we are starting to record the session right now, so thank you for joining us. Today, our webinar is Best Practices when Working with Interpreters to Improve Quality Care in Your Organization. My name is Joanna DeBow. I am the newest member of the NASA team at Proceed. I am originally from Portugal and grew up in Venezuela. I have over almost 10 years of experience in healthcare and education. I hold a master's degree in interpreting and translation studies from Wake Forest University and a master's of public health in a concentration with health education and promotion. Our featured speaker today is Ms. Jessica Salazar Ramirez. She holds a Master's of Arts in Interpreting and Translation Studies in Healthcare from Wake Forest University as well, and a Bachelor's of Science in Business Administration from High Point University, also in North Carolina. She has over 15 years of experience in developing and teaching of medical interpreting and translation curriculum and has worked as an adjunct instructor at different community colleges throughout North Carolina. I'm going to unmute Jessica very quick so she can say a quick hello. 1 second. I'm having some technical difficulties. I'm sorry. Right click. All right, I'm unable to get Jessica on the phone right now. She is on, but having some technical difficulties. So we're going to hold on that hello until it's her part. So some webinar participant guidelines. Just so you know, all your telephone lines will be placed on mute. Today's session is being recorded, as I mentioned before, and will be available upon request. Questions will be answered during the presentation and during the questions and answer session at the end. Please use the chat box to send us your questions and make comments throughout the presentation. The goal of the CBA for Health Equity, which is the one providing this webinar, is to build the capacity of leaders and staff with community-based health care settings to identify and address health inequities at the organization and community-wide level. Our official program hashtag is hashtag PROCIBA for CBA for Equity. You can also find us on Facebook, Twitter, Instagram, and LinkedIn. So please look for us and join us. All right, so let's get to know each other. I'm going to send some quick poll questions before we get started. So if you can take a second to answer. All right, our first poll question. We would like to know where your organization is located, so please take a few seconds to set that up. All right, a few more seconds. All right, I am going to be sharing the results. So 50% of our participants today are from the East region, 33% from the Southern, and we have 17% from Puerto Rico and the U.S. Virgin Islands. So welcome, everybody. Our next question, we would like to know what type of organization you represent. So please take a few seconds to do so. All right, a few more seconds to answer that. I'm closing the poll right now. All right, we have 17% of you from hospital medical group practices, 33% of you are from community health clinics and healthcare organizations. We have 8% from government agencies such as the CDC and 42% from other. Let's see what the comments are. We have planning council staff from Texas. We have governmental planning body. We have a CBO. Great, so we have a variety. And our last question is, we would like to know, what is your role where you are employed? So please take a few seconds for that. All right, I'm going to be closing the poll. Let's see. 29% of you are directors of program or program coordinators, 14% case managers, and 57% are others. Let's see what you wrote in the chat. All right, we have a consumer advocate interested in health disparities, and we have a counselor, which is great. So again, everybody, welcome. And let's continue. We are going to be learning today. Our learning objectives are: describe the LEP population in the United States, review the regulations requiring language services for these clients, categorize the different types of language services providers, identify qualified interpreters and expectations when working together, and we're going to end by discussing the best practices when working with interpreters. We're going to be achieving this through our agents, through our agenda. We're going to be discussing the demographics of the LEP population, our current regulations, the type of language services providers, and like I said, the best practices when working with them. All right, we're going to get officially started. So we're going to start by defining LEP. The LEP term refers to any person age 5 or older who reported speaking English less than very well as classified by the U.S. Census Bureau. The term English proficient refers to people who reported to speak only English or speak English very well. Out of the 327 million people living in the United States in 2010, 40 million or 12.7% were foreign-born residents. If we include also the U.S.-born residents, 20.6% or 57 million people claim to speak a language other than English at home. This number is increasing rapidly, as in 2013, this number increased to 61 million people speaking a different language at home. 25.2 million or 8.7% of people who speak other language than English claim to speak English less than very well. So these are our LEP clients and patients. LEPs are more likely to not have a high school diploma by age 25 at a rate of 46%, compared with a 10% of the English proficient immigrant counterpart. They're also less likely to have a bachelor's degree or higher at a rate of 14% versus 31% of their English proficient counterparts. About 25% of LEP individuals lived on households with an annual income below the official federal poverty line, nearly twice as high as the share of English proficient immigrants, which is 14%. Finally, speaking of health, compared to English-speaking patients, LEPs report having almost 45% low health literacy. A study analyzed adverse incident reports from 6 Joint Commission's accredited hospitals for LEP and English-speaking patients for 7 months in 2005. This study found that a greater percentage of LEP patients experienced physical harm versus English speaker patients at a rate of 49% to 30% versus 30%. Not surprisingly, LEP patients experience a significant greater proportion of adverse events attributably to communication than English speaker patients, at a rate of 52% versus 36%. This study is an example of the lack of language services can be a compromised issue to patient safety and healthcare quality. Hence the need for this webinar series. If you look at this map, you can see the growth of the LEP population number 1 through 10. The highest state with this growth is Nevada, with a growth of 398% from 1990 to 2010. The following states are North Carolina, Georgia, Arkansas, Tennessee, Nebraska, South Carolina, Utah, Washington, and Alabama, with a rate of growth of 202%. Now, if we look at the states in the map that are in dark blue, those are states with at least 10% of their population who is LEP. This is in contrast to the average nationwide of 8%. These states, colored in dark blue, are California with 20%, Texas and New York with 14%, New Jersey, Nevada, Florida, and Hawaii with 13%, and Arizona with a 10% of population who is LEP. Although we went deeper in our current regulations affecting LEP patients in the healthcare system during our webinar last week, let's have a quick review for those who did not attend and a reminder for those who did. If you can quick type in the chat, what do you know or have you ever heard about the class standards? You can raise your hand if you know what it is, or type yes in the chat box. And if you do not know or you're not sure if you ever heard about class standards, let me know on the chat box as well. I will give you a few seconds to answer. All right, we have somebody that does not know what class standards are. Somebody says after the first webinar, yes, which is great. Melissa Penley says she does not know. All right, so we have a good variety of people saying that they know or they have not heard, and some that they did after the first webinar, which is great. So let's talk about some current regulations. Title VI of the Civil Rights Act of 1964 establishes the services provided with the funding from federal government must be delivered without regard of race, color, or national origin. It considers the denial or delay of medical care due to language barriers to be discrimination based upon national origin. This means that any medical facility receiving federal funds such as Medicare or Medicaid must provide language assistance to LEP patients in order to be compliant. This means all of you who are here on this call. The August 2000 Executive Order 12166 refers to federal agencies to examine the services they provide, identify any need for services to those with limited English proficiency, and develop and implement a system to provide those services to LEP persons so they can have a meaningful access to them. In 2001, the U.S. Department of Health and Human Services Office of Minority Health issued 14 national standards for culturally and linguistic appropriate services. This is known as class standards. Class is intended to advance health equity, improve quality, and help eliminate healthcare disparities by providing a blueprint for individuals and healthcare organizations to implement culturally and linguistic appropriate services. Class is comprised of 15 standards, and they're divided into 1 principal standard and 3 enhanced themes. Theme 2, which is communication and language assistance, includes standards 5 through 8, is the focus of this series of webinars. It broadens the understanding and application of appropriate services to include all communication needs and services, such as sign language, braille, oral interpretation, and written translation. Another important piece of legislation that we need to discuss quick is the Affordable Care Act. The ACA extends previous mandates and explicitly requires insurances and healthcare institutions to provide written translation and interpreting service for LEP individuals of qualifying language groups. I have summarized the ACA's applicable regulations on the next 2 slides. So any organization that offers health services under the ACA must take reasonable steps to provide meaningful access to each LEP eligible individual. Publish taglines and non-English language in significant publications and on its website to notify individuals about availability of language assistance services. This includes your website. Offer qualified interpreters when oral interpretation is a reasonable step to provide an individual with meaningful access to care. Adhere to certain quality of standards in the delivery of language assistance and services. This also means that it is not appropriate by any ACA covered entity to offer language services and charge individuals an extra charge for the service, require an individual to provide his or her own interpreter. It is not recommended to rely on minors to interpret or rely on interpreters that the individual prefers when there are confidentiality and other concerns. It is also not recommended to rely on unqualified bilingual or multilingual staff or to use low-quality video remote interpreting services. If you would like to have more information about this, you can contact us and we can send you a recording of our webinar from Friday where we really explore a little bit more about this regulation. Also, if you want to learn more about CLAS, an excellent source is shared by Giselle Pemberton, which is thinkculturalhealth.hhs.gov. Thank you, Giselle. So if you have any questions about what we just discussed, this is a good time to pause and answer them. So please send them in your chat box. In the meantime, we're going to discuss a couple of frequently asked questions we received when discussing this demographic and the regulations. What is the threshold for providing language services under the ACA? What would you recommend for best practices? So the threshold for providing translation and interpreting for LEP patients is more than 10% of non-English speaking individuals in a county. This means that if within your organization, your community serves 10% of a population who speak the same language, you should be providing language services under the ACA. If your organization wants to improve that standard, I would recommend a threshold of 5% of any language to provide language services. How do I know if someone needs language services because they are LEPs? So a good general rule is to provide language services to anyone that requests it. We're not the person to decide if someone speaks English enough to have this discussion about their health in English and not on their preferred language. Remember, when offering language services, we're not necessarily looking at somebody who does not speak English or is not speaking English well. This is their preferred language for services. A person feels more comfortable speaking, in this case, about their health in a language that they truly understand. Hence, we consider language services in their preferred language, not in their first language. Also, a good practice is to use your triage employees to make a quick assessment for the need of an interpreter by asking open-ended questions, such as, how can I help you? Instead of things like, do you need any help? So by avoiding answers of yes or no and allowing the person to try to explain themselves of what they're looking for, what kind of services they're looking, we really can quick assess their quality or their level of English, so then we can respectfully provide language services if they will feel more comfortable getting the service this way. We have a quick question from Jeffrey Parks. He's asking, what about high quality video? Yes, high quality video is appropriate and is allowed under the ACA. Later on, Jessica is going to be talking about the different types of interpreting, including video and phone versus in-person interpreting. So I'm hoping that she can answer that question. If not, let us know at the end of the session and we can be more specific with what you would need. Thank you, Jeff. So before we pass along to Jessica, we're going to make another quick poll. We would like to know, who do you use as an interpreter in your organization? So you can choose more than one and let us know on a regular basis if you're in need of language services, who would you or who does your organization encourage to use? So please take a few seconds. All right, a few more seconds. All right, I'm going to close the poll and let's see the results. All right, so 33% use on-staff interpreters, 73% of you use bilingual staff that are clinical, and 47 bilingual staff that is non-clinical, and 7% of you use a family member or a volunteer. The great news is that none of you are unable to provide this kind of services, which is a great start. All right, so now Jessica is with the phone open, the phone line. So Jessica, would you like to say hello?
Yes, good afternoon, everyone. I'm so glad and excited to be here today.
All right, Jessica, all you, go ahead.
Awesome. Perfect. Well, great. Thank you so much for this covering this part of this webinar today. I think that all the information that we have been reviewing is very, very interesting and very applicable and useful for organizations. We are going to begin the next part of this webinar talking about interpreting and translation and what are the differences between these two ways to render messages. And if we can go to the next slide. So interpreting is a retransmission of a message from language A to language B in oral form. Besides language skills, interpreting requires essential skills from the individual in order to render an accurate rendition, like effective listening skills, analytical skills, ability to retain and recall information, and interpreting also includes signing for ASL, which is American Sign Language. And translation is the retransmission of a message from language A into language B in written form. Translation also requires language skills, being bilingual, but grants the individual the luxury of time to research cultural background, context, and localize the text. So the main difference in interpreting and translation is the way that is delivered, right? So interpreting is the oral rendition and the translation is the written rendition. And we're going to talk about techniques for interpreting. How is interpreting delivered? So we can see here that the first technique will be simultaneous interpreting. And simultaneous interpreting is the understanding and reformulating of a message in another language while the speaker or signer is still speaking or producing language. And the characteristic of this technique is that the interpreter is interpreting at the same time that the speaker is producing language. And it is mostly used in conferences and seminars or classes where there's one speaker, there's an audience listening to that speaker. Then we have consecutive interpreting. And consecutive interpreting is the understanding and reformulating of a message in another language after the speaker or signer pauses. This is the most popular method to deliver interpreting because it is the most organized method. Consecutive interpreting, again, the interpreter can interpret after the speaker has finalized given the message. Side translation is the oral rendering of the meaning of a written text. And then we have chuchotage, which is whisper interpreting, and it's mostly used as escort interpreting, a variation of simultaneous interpreting performed in a low voice for a public speaker and a small number of listeners. The word chuchotage is derived from the French chuchoter, which means to whisper. So as you can see in the image, there's the interpreter and he's talking like in a low voice, almost whispering to the person so that they can hear. And then we have remote interpreting. And remote interpret, before we get to that slide, remote interpreting is the interpreting that is done over the phone and includes video conferencing and media and etc. And I know somebody had a question about video interpreting, and we will get the opportunity to talk more about it later on this webinar. So that was a great question. And remote interpreting, it's interpreting that involves at least one interpreter who is not physically present with other parties to the session and who is interpreting using a remote distant platform. The types of interpreting services that can be offered in organizations include, of course, in-person interpreters, staff interpreters, part-time, full-time, contractors that are hired on as needed basis that can be hired for or contracted for one-time interaction or for different ones throughout a period of time. Then interpreting can also be delivered over the phone or video, which is called remote interpreting. We will continue. Now we're going to talk about the settings for the interpreting. Where can interpreter be conducted? And there are different settings. We have, as you can see here on the screen, the legal system or the legal setting, the business, medical setting, and the community. It's very particular to talk about the legal system because the formality of the setting is more organized than the rest of the settings that we're seeing here. In other words, the court system at the federal government level has organized very well the process for interpreters to become certified and for providers, of course, the court systems, to work through those interpreters. So we're not going to talk too much about legal interpreting today, but it is important that you know about the difference. It relies in the formality and how well organized it is as an organization. So now we're going to talk about ad hoc interpreters versus qualified trained interpreters. This is important because often it happens that the trained interpreters are not given the prestige that they deserve. So we're going to talk about this a little bit. On the next slide, and I would like to know if you can put on the chat here, other than the persons or the people that we can see here that are used or often used as ad hoc interpreters, and of course, ad hoc is a Latin term that means by chance. We see volunteers, family members, friends, bilingual staff, custodian. So I would like for you to put on the chat here on in the comments, who do you use in your organization? I know some of you have worked before with interpreters. So it is like very important because sometimes we ourselves get to interpret, right, for our clients or our patients. Let me take a quick look here. Profession. Awesome. Great. Thank you. Thank you, Giselle. Thank you. Thank you, Lauren, too, for your answer. Awesome. Okay. So continue with ad hoc interpreters. So what is it that is, why it's relevant to talk about ad hoc interpreters? And if we can go to we can see here before we go to the next slide, really quick, the ad hoc interpreters. Thank you. Just wanted to point out, if you notice at the bottom of this slide, it says another way that some people, find useful is to use a CAT tool or computerized assisted translation tool. Some people, they don't have anyone available to interpret and they need to communicate and they just, go for their device, their cell phones, and they use Google Translate or whatever tool they can find. And that is another way which, it is considered to be an ad hoc interpreter because it just by chance that was, you had the need and that's what was available at that time. So continuing with the next slide, this is a very, very good information here. So a study found that 23 to 52% of words and phrases interpreted by ad hoc interpreters That includes volunteers, bilingual staff, family members, and all the others that we listed on the previous slide, were incorrectly interpreting in analyzed encounters. This in contrast to the 2% error from a trained interpreter with at least 100 words of training. So these numbers, what they mean is once the researchers were able to listen to the renditions of these people, they found out that they were not really being very complete and accurate with their renditions. That means interpreting. So we can see here how ad hoc interpreters have never been tested for language proficiency. They are not trained, do not act impartially, omit important information, make many mistakes, often intrude, give opinions or share advice, and lack knowledge of specialized terminology. Children of all ages have been used to interpret for interactions involving their own pediatric appointments, diagnosis of fatal cancer of a parent, diagnosis of sexually transmitted diseases, even included HIV or AIDS of parents, and other adult family members. Appointments for their elders,
Jessica,
such as grandparents who had. Yes?
I'm
Yes.
sorry to interrupt you. We're having some very poor audio. Are you on speaker or using
Okay.
headphones by any chance? Can you just go to the phone
Speaker,
to
but
see if that makes it
is
better?
this better? Sure. Sure,
Yep,
I'm sorry.
let's try.
Yes, is this
Thank
better?
you. Sorry about that. Yes,
No,
continue.
no, it's okay. Thank you. So providers should be aware of the negative impact of using children as interpreters or ad hoc interpreters for that matter. If we continue with the next slide, and this is a very good example when interpreting goes wrong. In 35 claims, an insurance carrier paid $2,289,000 in damages and $2,793,800 in legal fees. Can you imagine that amount of money related to the failure to provide appropriate language services in healthcare? The cases resulted in many patients suffering death and irreparable
I'm sorry,
harm
Jessica.
to children.
Jessica,
Yes?
I'm sorry. You're chopping up again. I'm so sorry to interrupt you. This is Brenda, but you are chopping up again. So
Okay.
if you can maybe pick up your hand piece, it might be better.
I'm sorry. I do have the phone in my hand. I'm using the handheld. It's not the speaker.
Okay. It's okay. So let's see what happens. Continue, please.
Okay. I'm sorry. So this cases resulted in many patients suffering death and irreparable harm. 2 children and 3 adults died in one case. The deceased child was used as an interpreter before suffering respiratory arrest. And in another, the deceased child's 16-year-old sibling was used as interpreter. One patient was rendered comatose, one underwent a leg amputation, and a child suffered major organ damage. So all this because there was a failure from the organization to use trained interpreters and provide proper language services. In this specific case, in 32 of the 35 cases, the healthcare providers did not use competent interpreters. In 12 cases, family members or friends were used as interpreters, including minor children in 2 cases. Please let me know if I'm speaking too close to the phone. Can you hear me well?
It's a little better.
Hello? Thank you.
It's a little better.
I'm sorry, everybody. If we go to the next slide, and we're going to see another very good example of the perception in the part of the provider, and this is in regards to the medical field. So here is an example of a doctor that gives his opinion about using family or children as interpreters. And as you can see here, his statement was, I discourage use of a family member serving as an interpreter, even when a patient requests that a family member interpret. I don't think patients fully appreciate their own need for confidentiality or the types of questions I might need to ask. Sometimes questions asked may place patients in an awkward position, and they may not always reveal all of the medically necessary information. This is specifically true if that family member serving as an interpreter is a young adult. The only time I will use a family member is in an emergency. And as you can tell, it's really a very professional, mature way to perceive the negativity in using family members or any other ad hoc interpreter. The next slide here, we're going to see what are the qualities of a trained interpreter, what are the characteristics that we should look at when reviewing the services of a qualified interpreter. So qualified interpreters have subject knowledge and about of course, the terminology and the system and the field in which they are interpreting. They have language skills, they have effective listening and retention and recall skills, analytical, interpersonal skills. They know about the importance of discourse. They have ethical training, and they understand and promote the prestige and recognition of the interpreting profession. If you can see here, all these are very important characteristics that you expect to have from a professional trained interpreter. If we continue with the presentation, we can see here, we're going to talk about the national standards for interpreters. And this is an excellent informational tool to have at hand to know, what rules the behavior or the professionalism of interpreters. First, we have accuracy. And accuracy, the interpreter strives to render a message accurately, conveying the content and spirit of the original message, taking into consideration its cultural context. Then we have transparency. And this concept, every party involved in the interpreting interaction knows what is going on at all times. Confidentiality. The interpreter treats as confidential all information learned in the performance of their professional duties, while observing relevant requirements regarding disclosure. Then we have respect. The interpreter treats all parties with respect. That involves the client, the provider, and everyone else present at the time of the interaction. Cultural awareness. The interpreter maintains the boundaries of the professional role, refraining from personal involvement. We will get the opportunity to talk more about the roles of the interpreter here in a little bit through this webinar. Then we have role boundaries. The interpreter maintains the boundaries of the professional role, refraining from personal involvement. Professionalism. The interpreter must at all times act in a professional and ethical manner. Professional development. The interpreter strives to continually further his or her knowledge and skills. And finally, we have advocacy. When the patient's health, well-being, or dignity is at risk, the interpreter may be justified in acting as an advocate. Advocacy is understood as an action taken on behalf of an individual that goes beyond facilitating communication with the intention of supporting good health outcomes. Of course, advocacy must only be undertaken after careful and thoughtful analysis of the situation and if other less intrusive actions have not resolved the problem. This, again, are the national standards for the profession of interpreting, and they also guide us as to what to expect from interpreters. Any questions so far from the audience? If you do, please, as Joanna mentioned earlier, you can write them down on the questions. And I do apologize again for the audio. And please let me know if I need to stop or pause. I'll be glad to. So we go here now going to review the interpreting interaction. What involves the interaction? Who is involved in this? That is in this interaction and interchange of messages. So we have the provider, the interpreter, and the client or the patient. For interpreting to happen, we need to have these three parties present. On the next slide, we give an example of a very good example of a pre-session. And the pre-session gives the opportunity to the interpreter to establish the rapport and establish how things are going to work through the interpreter. So with a patient, the pre-session serves to introduce the interpreter, establish rapport, inform the patient as to how the interpreter will work, and allow the interpreter to assure that she or he can understand the patient's speech. With a provider, the pre-session serves to introduce the interpreter, establish a collegial relationship, inform the provider as to how the interpreter will work, and provide the opportunity for the provider to share any information about the upcoming session that might be helpful to the interpreter. So as you can see here, a good example would be, hello, my name is Jessica Salazar, and I am your Spanish interpreter for today. Please know that everything that happens during this encounter will remain confidential. I will interpret in the first person, and I will say everything exactly as you say it. I must interpret everything that you say. Please speak directly to the patient or the provider. I will ask you to pause frequently to allow the interpreter, which is, of course, you, with the interpreter, to interpret accurately and completely. In addition, I may need to ask for clarification. So again, this is an awesome opportunity for the interpreter to inform parties and ask whatever is needed from them to ensure that accuracy is reached throughout the conversation. If we go to the next slide, this is a very good point to make a reference to the importance of knowing and have contact with professional associations about interpreting. It is important to stay informed about the interpreting industry to maintain quality controls in your organizations. And professional associations offer a variety of services such as most current trends and best practices, access to listservs, newsletters, conferences and seminars, access to legal advice, networking opportunities, and online directories. So a great, great idea to find organizations that are professional associations for interpreting. On the next slide, we can see the this this module that shows the roles of the interpreter and how they apply into interpreting. So interpreters are professionals that facilitate communication between providers and clients or patients. Interpreters should not play an active role in interactions, but rather limit their participation to the accurate retransmission of the interchange of messages. In the conduit role, which is the one in the bottom of the screen, as you can see, this means straight interpreting. The interpreter limits their performance to interpreting everything being said with accuracy and completeness. In the clarifier role, in this role, the interpreter interrupts the interaction to ask for a clarification or to verify if a clarification is needed. In the cultural broker role, the interpreter can offer an understanding of a particular culture to clarify a cultural expression or custom or either the for either the provider or the client. And we can give the example here of an idiomatic expression. For example, if the provider says, "Oh, it's raining cats and dogs," in this role, the interpreter can offer the clarification that is an idiomatic expression and what it means. So to avoid a possible conflict in understanding what they're really meaning. In the advocate role, and we talked about advocacy on previous slides, that when the patient's health, well-being, or dignity is at risk, the interpreter may be justified in acting as an advocate. And of course, it's shown in the model here on this pyramid as the smallest role, right? Because it should be act on with care, because many errors can be done if an interpreter does not know their limits when interpreting. Then we're going to talk about special circumstances during interpreting interaction. And these are some of the special circumstances that can arise for interpreters. Children, especially teens who are English speakers, do not feel they need an interpreter and speak directly to the provider. But the parent who is an LEP person needs interpreting service, as she or he may not understand what is going on. The parent, as a legal guardian, needs to know everything that is happening in the encounter. So the interpreter becomes almost exclusively the interpreter for the family or the parents and not the patient, and interprets using chuchotage. Remember, we talked about chuchotage and how it is delivered almost in a whispering form or for one person. Unless the provider asks something directly to the parent or the parent wants to add something to the communication, then this is the method that is going to be used during the interaction. This is a special case for interpreters. As of 2013, of the 51.3 million children in ages 5 to 17 in the U.S., 8 million or 60% live at least with one LEP parent. So as you can see, this tells us that there is a need for interpreters to know how to offer chuchotage and to be aware that often the recipient, the person that needs the interpreting, is the parent and not the patient, when the patient is, of course, a minor. Client and patients may speak a dialect as their first language and only have a limited proficiency in the language in which an interpreter is available. And this refers to the different levels of a second language proficiency. For example, an individual may speak Yucatec Mayan as his first language and have a low or limited proficiency speaking Spanish. It is more likely to locate a Spanish interpreter than a Yucatec Mayan. And register, talking about language register and health literacy variances, the register refers to the formality of speech used by the speaker. Interpreter and provider should monitor the client patient is able to understand the formality of the speech that is being used as well as any specialized terminology. So as we can see, these are just important things to keep in mind in consideration when you as the provider are communicating with your clients or patients.
All right, thank you, Jessica.
Now we're gonna.
So we're gonna make.
You're welcome.
Go ahead. We're gonna make a quick pause. If you have any questions thus far, please go ahead and put it on the chat box. And in the meantime, I'm gonna ask Jessica also some frequently asked questions. Okay, Jessica, what could my organization implement to provide quality language services?
Well, as we have learned, organizations can develop standards for the provision and efficient use of language access services, providing daily support and guidance for questions, concerns, or issues involving interpreting and translation services to their staff, ensuring that proficient and professional foreign languages interpreters are provided to serve clients and, of course, the providers. If you didn't attend the first part of this series, send us an email and Joanna can send you the recording, which talks more about options. This is a good material to review to answer this question.
Thank you. The next question is it a good idea to allow clients to bring their own interpreter? And what would you recommend providers to do when this happens?
Well, it's definitely not a good idea. We recommend providers verify with their supervisors or agency director to verify the proper protocol to have a professional interpreter present during the interaction. Remember, a professional trained interpreter has the skills to successfully manage the communication between provider and client. The best practice for avoiding this is to have a policy prohibiting outside interpreters or family members or ad hoc interpreters, and if the patient insists to using his interpreter, the provider can bring his own interpreter. The provider is in charge of the interaction, so the provider can use the interpreter provided by the organization to make sure that the quality is achieved during the encounter.
Great. Let's see. No, there is a question coming from Jeffrey Parks. He says, we all encounter an interesting analogy of issues with interpretation translation services. When you can only hear or understand every other word, it poses huge communication issues. Thank you. That is quite true. Do you have any comment about that, Jess?
Definitely. Yes. So this is and thank you, Jeffrey, for offering this comment. Yes, this is a great example of when organizations and providers can identify the need for a trained interpreter, to have a professional that knows how to really accurately render a message. So this is a great example. Thank you, Jeffrey.
All right, Jessica, our last question here is, what advantages of in-person interpreting and remote services could you comment on?
Okay. In-person and remote interpreting services offer access to a variety of languages in a relatively short amount of time. The advantages of using remote interpreting include access to a diverse amount of languages, and it might be more cost efficient for organizations. Also, there's no need for family members or ad hoc interpreters to interpret when a telephone interpreter can be called in moments.
All right, thank you. And since we don't have any more questions or comments, let's continue with your next part of the session. After we do a quick poll, we would like to know how familiar you are with working with interpreters. So I'm going to open the poll really quick here. And if you can let us know, as of right now, how familiar are you with using interpreters within your organization? All right, a few more seconds to answer the poll question about how familiar you are with using interpreters within your organization. All right, I will be closing the poll in a second. All right, so we have 60% are very familiar, 10% are somewhat familiar, 20% are not very familiar, and 10% are not familiar at all. So thank you everybody who voted. All right, Jessica, continue please.
Excellent. Thank you. So now let's keep calm and talk about and call an interpreter. So we're going to talk about the best practices when working with interpreters. So the best practices to serve LEP clients is to establish policies for language services, designate a language access coordinator, identify who needs an interpreter, prohibit the use of ad hoc interpreters, especially children, as we have mentioned before, regular training for working with interpreters, requesting interpreting services, bilingual communication allowances. That means allowing proven bilingual staff to offer services in their second language, add extra time for the interaction during an appointment, report interpreting use on record, and implement a complaint and grievances process. We're going to talk about the intercultural and bilingual communication encounter, the interview, the interaction itself. And we're going to look at it from 3 standing points: prior, during, and after. On the next slide, we're going to see what happens prior to the encounter. Meet with the interpreter briefly to inform of the encounter. Allow the interpreter to conduct the pre-session, and we have had a chance to look at an example of what the pre-session looks like. Establish where the interpreter will be positioned, agree on the mode of interpreting to be used, and provide the interpreter with any written documentation in the other language that will help during the session. It is important to keep in mind that the positioning of the interpreter should be non-intrusive to you as the provider. So you're in charge. You may ask the interpreter where is the best position for that person to be. And again, allow the interpreter to conduct the pre-session. We put a special emphasis on this because this step is very important as it alleviates a lot of potential conflicts that could arise during the interaction. It is also a good idea to confirm the proper pronunciation of the names of the parties involved in the interaction and have an agreement on the mode of interpreting that is going to be used during the interview, and that it's simultaneous, consecutive, and all the other types that we talked about earlier. And of course, encourage the client or patient to let you know if any communication problems arise. Remember, as a provider, you should always be in charge of the interview. And if you have worked, before we continue this, I would like to know if you can put on the chat comments if you have worked, if you have used an interpreter before. That will be interesting to know if you guys have had that opportunity. If we go, any questions here so far as to how to prepare, what to do prior to the encounter, prior to the interaction? I'm just going to give it a couple seconds. You can put your comments again on the comment section. Awesome. Oh, thank you, Jeffrey. Great. Thank you. This is always good because then you have a baseline to compare, right, and offer comments on your previous experiences. Thank you. Thank you for doing that. Now, talking about during the encounter, of course, always address the client directly. Remember, the interpreter is only there to be used as a tool, as a conduit, as a way to communicate with the client, but not to replace the client or the patient. Use the first person when talking to the client, speak in short sentences, ask one question at a time, avoid idioms, acronyms, jargon, and humor, and give time to the interpreter to interpret. And this is a very, very, very good steps that you can do, to help the flow of the communication. Continuing with what, good practices to have during the encounter, do not assume you understand what is being said. Watch out for any signs of confusion throughout the interview. Interpreters should use incremental intervention in case of need to clarify or consult with either party, and avoid independent side conversations with other party. And one example of do not assume you understand what is being said as the provider is sometimes, and this happens specifically with Spanish English interpreters. I don't know if you guys have had this happen to you before, but the way the questions are asked in one language may not necessarily be the way that they're asked in that other language. For example, if a person asks, "Are you fasting?" then the interpreting part into Spanish or another into Spanish might sound like, "Have you had anything? Have you had food?" So the answer to "Have you had food?" is no, but the question from the provider was, "Are you fasting?" So as a provider, don't assume that when the client or the patient answers no, means no to your specific question, because there could be a need for the interpreter to actually, have to provide you with the correct answer. Is that understood? I would like to ask if that example makes sense. Why it's important not to assume that you understand what is being said. Please put your answer here. Thank you.
Can you repeat that? Could you repeat the example again to make sure? Lauren says, perfect sense.
Sure.
Totally says
sure. Thank you. So the example that I was given is the provider may ask, right? Or make the question, "Are you fasting?" But the translation, and this is, this part will be, of course, in Spanish, which is the example that the language that I'm using, will say, "Have you have anything to eat?" So the answer to "Have you have anything to eat?" will be no, but that no is responding to that translation, that and translation of that specific question. So it doesn't mean that the patient is not fasting, but has not the no was answering, "Have you had anything to eat?" So the answer to the original question from the provider, which was, "Are you fasting?" will be yes. Does that clarify?
That is an excellent question. That is an excellent example. That has happened to me so many times while I'm interpreting, and it's very important that, especially if you speak a little bit of the other language, you try to assume and understand before the interpreter finishes this job, and that can create such a simple question, a big misunderstanding. So thank you. Okay. Jeffrey also says fasting is not having ate for a certain time period. Anything to eat is very subjective, and everyone has a different definition of what means. And that is exactly right, Jeffrey.
Yes.
That is
exactly.
That's exactly to the example. Thank you. All right.
Yes. Thank you for that comment. So after the encounter, and these are some of the recommendations that you can, procure: debrief the interpreter on any cultural linguistic issues, provide interpreting supporting documents if requested, inform the interpreter or your institution of any issues or potential conflicts, sign proper paperwork related to the interpreter's participation, and make corrections to the record if necessary. If needed, again, this is a time to debrief the interpreter or on any cultural or linguistic issue that may have arisen during the interview. Provide the interpreter any special information that will be useful to maintain accuracy on your next interaction using interpreting. An example of this will be like printed literature that the interpreter may use on the next encounter. For example, if you're a provider that provides, let's say, services on uh, diet or specific diet for diabetic patients, you may have a certain list of recommendations for them, and that literature may be useful for the interpreter to refer to or to use the next time that you need that interpreter to manage again and help the flow of the communication. And of course, sign the proper paperwork and invoice and inform them of any follow-up appointments. Interpreters, most of the times, have to keep records of their time where they have been interpreting, and they can assist you to ensure that you have an interpreter present for the next time you need one. So again, these are all good practices to keep in mind. And now we're going to talk about communication tips. Realize that everything that is said will be interpreted. If you notice, we mentioned this earlier during the pre-session example, where the parties should know that everything that is spoken, anything that the interpreter can hear, will be interpreted. So if you don't want something to be interpreted, then don't say it out loud. Only one person should speak at a time, and avoid side conversations. Remember that the interpreter is a conduit, not the source of the message. Be aware that many concepts may not have a linguistic or conceptual equivalence, and again, this is something to keep in mind where that second language that we're using may not have a literal translation, and the interpreter has to come up with an equivalent term or concept to accommodate for that meaning to be transferred correctly. Of course, it always helps to be patient and allow the interpreter to be your cultural broker. Acknowledge the interpreter as a professional in communication. Respect his or her role. Realize that most patients understand some English. Do not make any comments you will not want them to hear. Transparency is vital for communication. Assume and insist that everything you say, everything the patient says, and everything that family members are saying will be interpreted. Ask the patient what he or he thinks the problem is, if there is some kind of conflict or problem, and if they do not hold the interpreter responsible for what the patient says or doesn't say. The interpreter is the medium, is the conduit, not the source of the message. If you feel that you are not getting the type of response you were expecting, restate the question or consult with the interpreter to better understand if there is a cultural barrier that is interfering with communication. That is always a good practice. Be aware that many concepts you express have no linguistic or conceptual equivalent in other languages. What we were talking about, the interpreter may have to paint word pictures of many terms you use. This may take longer than your original speech. Be patient. Providing care across a language barrier takes time. However, the time spent up front will be paid back by good rapport and clear communication that will avoid wasted time and dangerous misunderstandings. Again, it's always a good idea, good practice to take this little bit of time before the interaction to um, ensure good communication. Be aware of cultural factors that may affect the interaction, like family dynamics, communication differences, health literacy and differences. Avoid patronizing or infantilizing the patient. Ask the patient for their input on the issue being discussed. Use the teach back or show me technique to ensure client comprehension. Provide information and documentation in preferred language. If you decide to use a teach back or show me technique, ensure the patient comprehension is there, and that the message that you are intending to provide that client with is being received appropriately. Um, your patient may be a college professor or a medical doctor in her own country or their own country just as easily as she might be a farm worker. And this is just important to keep in mind that your client, just because they have that limitation in the language, it doesn't mean that they have or a limitation with comprehending your message. And again, all this material comes together, as we mentioned earlier, of the importance of ensuring communication and using good practices and using trained interpreters when communicating with clients or patients. And this is all the practices that we have. I don't know if somebody has a question at this time. Any questions? No? Okay. Well, Joanna, this is infantilizing the patient. Love it. Oh, thank you. Thank you, Jeffrey. Thank you. Oh, you're welcome, Lauren. Thank you. I'm glad that you find it informative. Thank you. Yeah, if you have any questions, let me know. And I don't know if Joanna can hear me. Hello? If you can hear me, please let me know. Thank you. Thank you for thinking that this is
Hi, everybody. I am so sorry. We just noticed that something happened. So, Jessica, you're still here with us?
yes, yes. I'm so
All
sorry,
right.
Jess. I don't know what happened there.
All
I'm
right.
here. I'm here.
Okay, thank you. Do you want to go ahead and do this communication tips? Were you able to do it?
Sure. Yes. The following with the communications tips that we would like for you to have, be aware of cultural factors that may affect the interaction, like family dynamics, communication differences, and health literacy and differences. Avoid patronizing or infantilizing the patient. And I saw a comment from Jeffrey there about that. You like that? I'm glad it's good. Good. Some of these points are very, very useful and very real. Ask the patient for their input on the issue being discussed. Use a teach back or show me technique to ensure client comprehension. And of course, provide information on documentation in preferred language. So this completes the recommendations that we have for best practices when using an interpreter and communicating to with a patient that is an LEP, and hopefully you will be able to use them and apply them. And
Thank you,
I hope that
Jessica.
if you have any questions, please let me know. Hmm.
So while people asking their questions, I was just going to add a little bit on this slide because I thought that you went off, so I started talking without realizing that I was the one that was gone. So I wanted to give you, I was trying to give the participants an example of how important the family dynamics are and the teach back. So in a lot of cultures, it's very important to make family decisions and not individual decisions. So it's very important for a practitioner and provider to respect when a patient is saying, I can't make a decision about doing this procedure or not. I need to talk it to my family. It's part of that. And this goes back into, bringing input from the patient, so you really understand how their health is affected by their culture by asking them what's going on, what do you think? So it makes them really feel involved with the situation. And then the teach back technique, we not only encourage it for LEPs, but for everybody. It's a good practice on healthcare to make sure that the client is really understanding. So really asking them, tell me back what's going to happen, or can you explain to me how you're going to take this medication, because you really want to make sure this person is leaving with what they need. So that is very, very important. And Jeffrey also agrees that the teach back is very valuable. And because it is very, very important, especially when we're dealing with a population, not just the LEP, but in general, a population with low health literacy. It is very important that, they're understanding what we're trying to come across during our encounter. So if there are not any questions, I don't see any. I'm going to continue, but if you do have a question, please go ahead. Here are some good resources that you can use to get more information about working with interpreters. If you have any additional questions, please feel free to contact me. And here I have my coworker, Brenda Cruz. She is the manager of NASA, and she can also, help you as well. And if you want to receive individualized CBA, please contact us. We'll be more than happy to provide any type of technical assistance or training, especially regarding to language services. So would definitely be a good resource for you. After this, you're going to complete a quick evaluation. So please take a few minutes to do that. It's very, very important for us to obtain feedback from you. If anyone is participating in the webinar in a group, please let us know as well in the chat box very quick, so we know that there's more than you behind, one person behind that word, that name. And at the end of the webinar, you will be getting an email with a handout, which is going to summarize the best practices that we discussed today. And also, if you want a recording of this webinar as well as the one on Friday, don't hesitate in contacting us. Thank you so much, everybody, for being here, and we very much appreciate it. Let me check. I don't think we have any questions. So if you do later on, please go ahead and send us an email. And again, please take a few minutes to do the evaluation. Thank you so much. Thank you, Jessica, for taking from your precious time. I know you're very busy. We very much appreciate your very knowledgeable input on this. So thank you, everybody, and have a wonderful day. We're going to leave the lines open just for a few minutes. Jessica?
Yes, my pleasure. Just wanted to thank everybody. Thank you. And Brenda, thank you for this opportunity. And I'm very excited for the next one.
Thank you, Jessica. All right, everybody. Jessica. I'm going to mute Jessica. And if you have any questions or comments, please put it in the chat. If not, we will see you on our next webinar.
If you have any topics that you're extremely interested in learning more about related to health equity, cultural competence, class, or even today's topic, please let us know as well by sending us an email or putting in the chat box if it's on your mind right now. Thank you once again, and happy holidays.